Oh, you did already?
Yeah.
Good. Hopefully things will work a bit better than last time because we had a couple glitches, but hopefully we're over that and we won't have the same trouble this time. As Laura said, if you've got any questions, if you put them in the chat section, and we'll try and keep an eye out for that. Laura, please feel free to interrupt me if you want to address a question that arises if I haven't seen it. But welcome back to part 2 of the webinar series on financial sustainability through Medicare turmoil. And we've seen in the news just this week a little bit more action around the issue of the Medicare freeze, and AMA in particular trying to agitate that decisions be reversed. Personally, I'm not optimistic that that's going to happen, and we've just got to keep moving on, expecting that the decision won't be reversed. So last week we had a close look at Medicare, including a review of some of the historical trends, as you can see on the screen there, and the financial challenges that that has presented. This chart in particular demonstrates the growing divide between the indexation of Medicare and CPI indexation over time. And this is really the fundamental reason why practices that are solely reliant on Medicare, those practices at 100% bulk billing, have essentially a flawed business model that is not sustainable over time. We finished last week's webinar with this chart and demonstrated that for an average GP earning $400,000, the cumulative impact of the Medicare freeze will be about $73,450 when we measure that against a target profit growth rate of about 3% annually. So if our intent was to grow the business and grow the profit at about 3%, because of the Medicare freeze, if we don't increase our fees at all, if we don't have any extra patients, etc., we estimate the impact over that period would be $73,000, which is obviously significant. This week, we'll look at the strategies for how practices can respond to this challenge in terms of fee setting, and also looking at creating a more sustainable models of practice. So what is your approach to fee setting? It's interesting that when I've gone out and seen quite a few practices, I would say that most of them do not have a well-structured or defined approach to fee setting. There's not really a system in place for how they determine an increase. Some of them might just add $1 across all their gaps every year. Some might just wait for a few years and then decide, oh, it's about time that we increase our fees. For most of them, there's no real science or calculation behind the way in which they determine what level their fees should be increased. Practices really should have an incremental approach to increasing fees, so that they are reviewed and adjusted at least annually. Revenue that's lost by failing to increase fees can never be recovered, so it's important to keep that in mind. If you don't increase your fees this year, that you'll never get that revenue back. It can't be recovered, and it's made worse when you consider the compounding effects on that loss each year. From a patient's point of view, I expect that small incremental increases are more palatable than consumers having a significant hike every couple of years. Because it's similar to the frog in the boiling water approach, that if you change things slowly, it's often people don't take as much notice. The decision about what level you want to increase your fees will really depend on what you're trying to achieve. And on the screen here, suggesting that for some practices, it's about trying to match the fees with your budgeted forecast of expenditure. So if you know that your expenditure is going to go up $50,000 next year, to try and match to set your fees so that you would at least generate an additional $50,000 to cover that increased cost. The other way of looking at it is to match the profit that you're looking for, whether that be an increase along the lines of CPI or the 3% that I've been talking about. If you actually look at what profit increase you're trying to achieve and then set your fees to try and match that increase. The answer to I guess for each practice this is going to be different, and it's really important to keep in mind what the principals of the practice are wanting to achieve financially. We also need to be mindful of the patient's capacity to pay and the balance that balance that off with the necessity of developing growth in the business. And this really takes us back to that discussion I had last week about the perpetual balancing of the conflicting values of trying to make a profit but also providing a community service. And so we have that challenge. We need to make sure that the fees are set that they're affordable, but we also need to try and deliver business growth. And there is the challenge, especially with the Medicare freeze ahead of us for the next 3 years. So what we've done is calculate a couple of scenarios here to demonstrate the factors to take into account when fee setting. So if we look at this example, we've showed the difference in the fees for this year at $400,000 compared to what we look at for next year. And if we're wanting to achieve 3% growth, we would need, it shows you that we need to increase our fees overall by $12,000. Now in this example, we've used a rate of percentage of concessional versus non-concessional. And those rates are based on the Beach report. So the University of Sydney Beach report that suggests that the average concessional rates of attendances is 54.4%. So based on those figures, we've then been able to work out to achieve that $12,000 increase in the year 15-16, we need to increase the non-concessional rates by about 6.6%. And you can see the bottom line there. For a standard fee of say $67.05, the increase would need to be $4.43 to achieve that level of growth. We've used $67 because that's a gap of a co-payment of about of $30 for a standard consultation. So that gives you one example of how to look at the increase for fees. In the next example, what I've done is to demonstrate we've used a different percentage, because in the first example we used the percentage of concessional versus non-concessional. But we know that in practice our bulk billing rates are often higher than just the concessional rates. The practices often bulk bill non-concessional patients for some of their services as well. And so in this example, it shows a split where the practice is bulk billing 75% of the patients and only 25% of the patients are private billing. So to achieve a $12,000 increase for next year, the practice will actually have to increase the private billing fees by about 12%. And you can see the bottom line there that increase is actually as high as $8.05. So the difference from the previous example is because we're recovering that $12,000 from a much smaller patient base. The Medicare freeze means that there's no revenue growth from the bulk billed attendances. For example, that 75% that are bulk billed. So the full burden of the desired growth will be borne by the private fee-paying patients. I'm not advocating here that you should all go and increase your fees by $8, so please don't be anxious about that. The purpose of these examples is to demonstrate that in the current Medicare freeze environment, the burden of growth is fully on your private cohort. It may be that through this period, practices have a goal of increasing their revenue it may be that through this period, one of the things that practices have a goal at is really trying to reduce their bulk billing rate. Because we'll see as we go through this that if you can reduce your bulk billing rate, you'll also lessen the impact of the freeze. In this slide, I've just demonstrated probably a more simplistic way of making that calculation. So looking at a bulk billing rate model, the idea is that the required increase will equal whatever CPI is, or whatever your growth rate that you're trying to obtain, divided by your bulk billing rate. So in this example, if a practice has a bulk billing rate of 60%, the required increase is, and we want to achieve 3% growth, the required increase would be the 3% divided by the private billing rate of 40%, and gives you a result of a 7.5% increase. So on a standard fee, the increase of $67.05, the increase would need to be about $5. This next table shows you a couple scenarios there. So that if we look at practice A's bulk billing rate is quite high, and so because of that bulk billing rate, wanting to achieve a 3% level of growth, the fee increase will need to be up to about $8.05. In practice B, the bulk billing rate of 75% still applies, but the indexation rate that I've put there is about 1.3%. And if we look at, and I've used Adelaide's CPI increase over the last 12 months, Adelaide's increase has been only 1.3%. So it's reasonable maybe to apply the actual CPI increase to fees. And that shows that the percentage increase for that same practice with a bulk billing rate of 75% is only 5.2% overall for the fees, and so the bottom line there is an increase of $3.49. If we look at practice C, what I've done there is to drop the bulk billing rate, and if you compare practice A to practice C, you'll see the impact of a 15% bulk billing rate. That if your bulk billing rate is less, then you won't have to increase your fees as much to get the same level of growth that you're trying to achieve. And practice D shows you a similar example, but using the indexation at 1.3%, which is the actual CPI index rate in Adelaide. And so out of those models, you can see that probably B and D are probably at a rate that is consumable for patients to accept in the short term. I'm not here to tell you what rate to increase your fees by, but what I'm doing today is to really give you some way or perspective, an approach, shall we say, for how to actually calculate the way you increase your fees in your practice. From doing this sort of exercise and presenting this for the practice to make a decision on, once you've worked out the approach that you're going to use in your practice, you can then use that approach in the next year and the year after that. And so if you have a consistent approach to how you set your fees and you do it annually, it will hold you in good stead as you increase your fees moving forward. The other thing I wanted to highlight with fee setting, that it's appropriate and a good strategy to consider whether you set higher prices for premium services. And that might be any specialist services that your practice provides. I've got the example there of skin clinics. GP procedural services. So if you have GP proceduralists working in your practice, and I'll talk about that a little bit more in a moment, and also looking at things like your after-hours services. I know that some rural practices put charge a higher co-payment for after-hours services as a way of discouraging patients from accessing those services via the hospital instead of accessing them during the day through the clinic. And I'm also aware of a couple practices that have put in higher prices for priority access, in that they might bulk bill the majority of the patients, but if a patient wants to be seen by their preferred doctor on a specific day, that they actually charge a co-payment or a premium price for that service. If we look particularly at procedural services, I know that rural practices are often delivering procedural services to their from within their practice or to their local hospital. The patients who are accessing those services would otherwise have to go to probably one of the major regional centres or a city to access that care. And in that regard, it's probably warrants that a higher fee be charged for those services. Those proceduralists also have to do additional training to maintain their skills and expertise in that area, and have also additional costs in terms of their medical indemnity. So if you haven't already done so, it may be worth considering a policy of not bulk billing any of your procedural services, so that you actually ensure that patients pay a gap of some sort, whether it's a premium gap or a standard gap or a concessional gap, for the GP procedural services they require. You might also consider this for services procedures such as biopsies and excisions, where sometimes the Medicare rebates don't really adequately remunerate for the time that's involved in conducting those procedures. So there's some areas where you might not want to put increased fees across every part of all the services provided, but you might want to focus on some of the services that you can put a higher premium on. Other than fee setting, I guess what else can practices do to make them more financially sustainable? And so the next few slides we're going to look at some opportunities for increasing financial sustainability that's not about just about fee setting. I guess the main opportunity through Medicare is to focus on delivering more health assessments and chronic disease care, including reviews and also medication reviews through the practice. I guess the principle that I'm looking here is about maximising the revenue gained in a standard GP consultation timeframe. So what are the opportunities for maximising every 15 minutes of your GP's time? The table here shows the potential revenue that can be generated using these items, even taking into account the cost of the nurse involvement. Now, I just noticed on the net, the top there, that's supposed to be a dollar sign next to 37.05, so sorry for that. But it does show you the significant difference between the revenue that can be generated from a health assessment or care plans or for signing off on a medication review with the patient compared to the $37 that were received from a standard consult, 15-minute consult. Practices that use these opportunities to a varying degree, and I think the crisis of the Medicare freeze is a good opportunity for you to consider if there are ways in which you can make better use of these items. Can you implement a more structured and productive system for completing health assessments and chronic disease management services? Can you do more with HMRs in consultation with your local pharmacist? The other opportunity is that is through practice nursing services. Practice nurses, the services have increased significantly across the nation from the time when there were nurse-specific items introduced for immunisations, wound care and pap smears. These items were eventually replaced by the Practice Nurse Incentive Program, and in my experience, the majority of practices are actually better off with the Practice Nurse Incentive funding. The problem is that in general practice we're fixated by Medicare items for revenue, and so if there's no Medicare item we don't think there's any revenue opportunity to be made. But the reality is with our nursing services, people do value the service that our nurses provide. There is an opportunity to put a price on that value that they have for the service that they receive. And I've got a couple of examples here around wound care and pap smears. With wound care, I know that in the practice in Clare, there are patients that actually choose to go to the practice and pay for their dressing rather than waiting at home for a cheaper or free community nursing service. They find it more convenient, they know when they're going to have that service, and they sometimes prefer the nurses that we offer through the practice. Most practices are also trying to recoup the cost of the dressings that are charged, are being consumed by the patient at the time, and so there is an opportunity to charge a private fee for a nurse consult plus also the consumable cost for that to minimise the financial impact on the practice. Previously, when we had a nurse item and we were bulk billing through Medicare, it wasn't always possible. It wasn't possible to bulk bill that service and to charge a consumable cost. But when you're charging a private fee for the nurse, it is possible to charge that consumable cost at the same time. The other example I've got there is a lot of practices, when the Practice Nurse Incentive Program came in, a lot of practices reverted to the GP doing the pap smears because there wasn't a nurse item to use, and the doctors in those practices felt it was more cost effective for them to be doing the pap smears. I guess the other option for practices would be to offer the opportunity for a private service to patients so that they could choose whether or not that they receive their pap smear by the practice nurse, or whether they, and for example I've put up there, if we charge a $25 fee for the practice nurse, or they're given the choice of seeing their usual GP for that service and paying their usual $30 gap. So the example there is to say that there is an opportunity to put that back to the patient and say we've got these two options, the nurse at a slightly less rate or the doctor at whatever your normal gap is, and to let those patients choose. And I know that in a lot of practices their experience is that the patients will choose to have that service provided by the nurse. The other strategy for sustainable practice is around effective appointment structures, to using our appointment structure to actually drive financial outcomes. And I think what happens in practices is we have our appointments set up the way that they are set up, and very rarely do we go back and have a look at is the appointment structure actually working in the best way it possibly can to provide the services we need to provide, but also to generate the financial outcomes that we're seeking. I've got this chart up here just to show you the differences between the structures of appointments. So if, for example, and we'll drop right down to the bottom, if, for example, a doctor was seeing patients 5-minutely, and some of you might be aghast to think that that actually happens, but unfortunately it does, that if they saw 12 patients per hour, they would be able to generate $200. We actually see that by seeing less patients, in terms of 10 patients per hour, because that would mean that the average consult would go over 6 minutes. The revenue would actually jump up to $370 per hour. So I'll let you have a look at that. The interesting one that I find is the appointments at $3 per. The appointment scheduling at 3 patients per hour compared to 4 patients per hour, because a lot of traditional practices are set up to see 4 patients per hour, and based on the average consult in that time generating an item 23, that would generate $148. But if practices actually strategically saw 3 patients per hour, just clicking onto that 20 minutes and charging the 36, they could generate $215 per hour. The reality is it doesn't work always that way, and you know that as well as I do. But it's interesting that I did some work with an organisation that was actually looking at that model, that they were going to target every consult lasting 20 minutes to generate the maximum value they could out of that hour. I'm certainly not condoning that. I'm just letting you know that that's how some people have had it looked at their appointment schedule and the modelling of that. The top row there shows you if you have 2 patients per hour for 30 minutes each, and the doctor completes a EPC care plan claiming items 721 and 723, that in that hour the doctor would generate $506.90. Now, even with the cost of a nurse at say $60 an hour, they would still be generating a lot more income than they could otherwise generate. In terms of other strategies for the appointment book, I've seen a lot of practices consider putting FastTrack schedules together for repeat scripts and referrals, and that's because, and you may find in your practice as well, patients coming in for repeat scripts and referrals, sometimes that's a major distraction and a difficulty actually rostering those in and getting patients in seen on time and efficiently dealing with that work. Some practices have found by actually setting up a specific session for FastTrack appointments that are 5-minute appointments only, bulk billed for the single issue, that they're able to actually work through that work more efficiently and to generate more revenue through that. The real key issue with a FastTrack schedule is to ensure that the patient is aware that they're only coming in for that one issue, that they're coming in for their repeat script or their referral, and that other issues shouldn't be brought into that consultation. It really involves a lot of education for your reception staff, for your doctors, and for the patients to understand that this is how it works. And the practices that do it well are practices that demonstrate that they're quite disciplined about that. The practices that have said, oh, we've tried that but it didn't work, are usually practices where that collective discipline doesn't apply, that it gets sabotaged by one or the other not actually abiding by the rules that are set down. It's worth considering, and it does work in some environments, and you'll know your people, your doctors, and whether or not that's going to work for you. The other model that we've been trialling at one of the practices is a model called butterfly consulting, and in this model, I'll show you on the screen, the GP actually works with 2 nurses in doing a full session on chronic disease care only. And so this example here shows you that the nurses do spend time with the patients doing a care plan or a care plan review, and then go in and join the doctor with the doctor's appointment as part of that care. So the doctor working with 2 nurses side by side can fill a session full of chronic disease type of work. There are a couple of appointments in there, the GP only review appointments, and they're often filled with HMR type reviews, or other reviews for where only the doctor needs to see the patient and the nurse intervention's not required. So that's an interesting trial, and what we've found through that is we're probably generating $200 to $300 more per session net, taking into account the cost of the nurse or the nurses involved. But the real impressive thing about this model is that we're providing that we're finding that we're able to provide, I guess, a more focused service around chronic disease management. It's more structured. We seem to have created better efficiencies through how it works, and improved financial outcomes. So I guess the point of that is to say that if you haven't looked at your appointment book for a while, it's worthwhile going back and looking at the structure of it and to analyse, is the appointment book enabling you to achieve what you want to achieve in terms of the services you want to provide? Is it achieving what you want to achieve in terms of maximising the financial benefits that could be generated for the services that you provide? The other important area for sustainable practice is around increasing practice efficiency. And this is a key area that when I go into practices, I often see a lot of inefficiencies through how they're structured and work. Things like looking at some of those procedures that are recurrent and time-consuming, and seeing whether there are some steps or some avenues for actually fine-tuning those procedures. For example, the reminder and recall procedures, they can be very time-consuming, and so looking at ways in which those procedures can actually be managed in the most efficient manner. Another example is the financial procedures. So if you're involved in managing the finances within the practice, you might know that over time things change, and so your systems and processes need to adapt with what changes in the financial environment. So, for example, when GST came in, everyone had to change their financial systems. But after a while, it's actually worth taking a stock take about why are you doing the processes that you're doing, and is there a more efficient way to be doing those processes. And I sat down with one practice manager and their accountant and worked through for a whole day looking at their financial processes, and after investing that one day we were able to save that practice manager 2 days a fortnight in time efficiencies. So it's sometimes worth taking a step back from the busyness of what you're doing to work out whether that you can streamline things more than you currently have. The other thing that I see commonly in practices is that for example, I might ask a receptionist, how do you do a certain simple procedure at reception? And the answer that they will give is, I do it that way for Dr. A, I do it this way for Dr. B, I do it that way for Dr. C, and that way for Dr. D. So if you've got 8 different doctors, that receptionist may have 8 different subtle changes to a procedure, a simple procedure, to accommodate all of those the doctors in the practice. And so it's a constant challenge for practice managers to actually work with and look at how do we simplify what needs to happen, especially at that reception desk. How do we simplify it so that there is one procedure for every process that's involved, so that there are not too many situations where receptionists are having to adapt what they do to suit the idiosyncrasies of each of the doctors in the practice. You'll be surprised how many times you will see that in action, but you can also be surprised how much more efficient you can make your practice by, in the end, trying to get agreement on the one procedure that's used across all practitioners. The other thing that you might look at is efficiency in terms of billing, things like online claiming and using Tyro. And I might, if I get a chance, I'll talk about that a little bit later. Online appointment books is another area of efficiency, and a lot of practices are looking at online appointments. For metropolitan practices, this has become a big issue because it's also an important part of their marketing. Often they need to have an online appointment presence to generate referrals or patients accessing their practice. In rural practices, it's not as big an issue from a marketing point of view, but it certainly could streamline the efficiencies at the front desk at reception if more patients were making appointments online than ringing and consuming time on the phone. Something worth considering anyway. So there are a few ways in which practices can try and adapt and make the practice operations more sustainable for the future. So using the challenge of the financial situation at the moment, the challenge of the Medicare freeze, I'm encouraging you to consider what ways in which your practice can look at how it operates and try and work out ways in which it can ensure that it is more sustainable for the future. I'm going to change a little bit of tack now and talk about implementing fee changes. So hypothetically, if you were a practice going from 100% bulk billing to deciding that you were going to start charging privately for your non-concession patients, that would be a huge change management process. But realistically, if you're increasing your fees in one to some degree or making a change to your fees policy, that is still an important process that you need to work through and think through, and these principles that I'm going to talk to would still apply. But probably think about it in terms of a practice making that big change from 100% bulk billing to private to mixed billing type of model. The key things that would need to be put in place are having a billing policy, a debt prevention policy, and also a debt recovery policy. It's interesting, a lot of practices that I go into, there isn't a really clear billing policy. There's not a consensus amongst all the doctors about this is how we bill here, and that creates a challenge at the front desk. It creates a challenge for patients who are often confused by what is happening in that practice. So practices might know that they bulk bill or private bill or whatever, but they don't really know or have it written that it's clearly understood about all the details of their billing policy. So I'd encourage you to think about that and think about these three elements. What is the service fee? When is payment required? And what modes of payment are available? If you are private billing, when does the doctor use their discretion to bulk bill, and what are the rules around bulk billing for non-concession patients? The really crucial issue here is about consistency, and a billing policy is a really good way of getting that consistency, so that when patients come in and out, they're receiving their service in a consistent way, and the billing for those services is consistent as well. An important part of managing managing the billing is a debt prevention policy. And in this regard, prevention is better than the cure. Preventing debt is the best way to manage your debt. And the key issue there is about expecting a payment on the day. And I think that dental practices do this really well. I'm not sure, there's not many of us who have actually been to a dental practice and they've said, yeah, don't worry, you can pay later, or you don't have to pay on the day. Every time I've been to a dental practice, you're told in advance this is what you're going to pay, and when you go there, you're expected to pay on the day. And that's something that we can learn from in general practice. I think the difficulty for general practices is that we're not always certain about what the bill is going to be for the patient coming out at the end of the day, because it really depends on the service that they receive, and we don't know that beforehand. But we certainly can advise patients that they are expected, that there is likely to be a cost, and that they are expected to pay on the day. And the use of tools like Tyro can certainly help to make the collection of payments much easier. If patients are able to come in and to pay with their card and receive their rebate probably by the time they actually get back out into the car park, it's a lot more palatable for them to be paying on the day. So if you haven't looked into Tyro as a way of collecting fees, it's something that's worth looking into and following up. The other part that's important around prevention is ensuring that staff are educated, making sure that your receptionists are giving consistent and clear messages to patients when they're ringing up and making their appointments, making sure that patients are aware that when they come into the practice that there's going to be a cost and what they're expected to pay. Debt recovery is a challenge as well, and it's worthwhile being clear about what your debt recovery policy is. Do you have regular follow-up letters? Do you have a process in place where patients are sent out letters at 30 days, 60 days for any debts that are outstanding, or somebody who makes phone calls to inquire about debts that are outstanding? Do you have alerts on your system so that when a patient makes an appointment that the reception staff can advise them that they have money outstanding and that they should be paying? Do you have a policy that if patients don't pay their debts after a reasonable period that their service could be withdrawn? And that's a really tough one. I know, especially if you're the only practice in a rural town, it's difficult to say to a patient that you'll withdraw their service. It's a real challenge, and I guess I understand if you have to work out alternative ways around that. But if you are able to put that type of policy in place, I know that it is really effective. So that patients, if they want to have a service, they need to pay their outstanding debts before they access that care. The other issues in rural practice is that I know that you also have to be available to respond to emergencies, so we can't be haggling over whether a patient has paid their debt when they're in a dire emergency case. But it's worthwhile thinking through these scenarios and seeing what are your options. The crucial issue, if you do have a withdrawal of service policy, is to have accurate documentation, to make sure it's documented at reception when patients are informed about the cost of services, that it's documented at every stage that the patient has been contacted to pay their account, that it's documented that when they have been told that their service would be withdrawn. I guess the adage here is that you don't need a debt recovery policy if your debt prevention policy has been implemented correctly. And it's about creating that expectation of payment on the day. If people pay on the day, then we won't have debts to follow up. Again, in rural areas, if you're providing outpatient services and charging for a cost for or a gap co-payment for those outpatient services, that can be a really difficult thing if you're not able to collect the money at the time. And I know that in rural practices, especially in South Australia, where that's a common practice to charge a co-payment for outpatient services, that is often the area of biggest outstanding debt for those practices. I guess the crucial issue is in any change is about communication, and it's important to internally to have communication with all employees, doctors in the planning and implementation of those changes. It's important to communicate effectively with all your stakeholders who are involved with any of the changes. It's important to inform patients and to explain how the change will benefit them if you can do that. Ideally, if you're going to make a significant change with your billing policy, it's good to give a lead-up time so that patients know that that's going to happen and they can be prepared for that at the time. It's also worth noting that if you change your policy, you might be dutiful in the first 3, 6, 12 months in advising patients that that policy has changed. But we know that some patients don't come to see the practice every 3, 6, 12 months, and so it's important to try and continue to let patients know what your policy is about payment, because you might have a patient attend who hasn't been to your practice for 3 years and not expected to have and didn't expect to pay because they didn't pay last time they were there. So from a management point of view, the things we need to do to implement a change, especially around billing practices, is looking at your drafting a billing policy and a debt prevention policy, being prepared if there's any cash flow decline or any impact on cash flow, reviewing your insurances about holding cash. So if practices are going from 100% bulk billing to charging a private fee, they're probably going to need some insurance for holding cash in hand. Reviewing any security policies that relate to the management of cash and getting cash to the bank, and also ensuring that compliance is always with the ACCC requirements. From an implementation point of view, the critical thing is to make it easy for patients to pay, using systems like Tyro that make it easy for them to pay, easier for them to pay, and to have their money returned into their bank account within seconds of the transaction. Making it easy for reception to collect the money. If your fees are set at a certain rate and they're trying to collect 5 cents here and 10 cents there, it makes it a bit more challenging. Usually rounding up so that they're collecting whole dollars makes it a little bit easier. Being important, if you're a practice that didn't previously collect any fees over the counter, it's important to understand that the staff would need to be trained about handling money. And the other issue is also that's critical is training staff in terms of managing aggressive behaviour. And I'll talk about that a little bit more on the next slide, because one of the things that happens if you change and make a significant change to your fees policy is that you will get some pushback from patients, and that sometimes flows into anger and aggression. And so I've got some hints here in terms of handling those objectors. It's important to acknowledge the anger and show a real desire to resolve the issue. It's important to provide patients with information on billing and potentially some different payment options. So if they weren't prepared to pay that amount in full, maybe you can work with the patient with a payment plan for how they would get that payment finalised. And again, I guess negotiating payment for that current consultation or for future consultations, how is that going to be resolved for that patient in the future? The critical issue is about having a no tolerance policy, and if patient behaviour steps over into being abusive or aggressive to your staff, we all have, I guess, workplace health and safety responsibilities. We have a responsibility to the welfare and well-being of our staff, and a critical part of that is by having a no tolerance policy and ensuring that patients are aware that abusive and aggressive behaviour isn't acceptable. So that goes across all of what we do, but particularly at the reception desk when you're dealing with money, that is often when abusive and aggressive behaviour can arise. Changes that are made to your billing practices and that, we often don't realise that the impact that that's having on our patients, and it creates anxiety for them, and that impact often comes back to our reception staff. So we need to do what we can to take care of them in that way. So there's been a lot to go through today, and I've come to the end of what we're going to cover today. Next week we're going to look a little bit more of I guess sustainable business. What are the business things we need to look at in terms of budgeting and key performance indicators, and also benchmarking? So looking at that from a financial point of view, for practice managers, what are the aspects of the financial management side of your role do we need to look at, and hopefully provide you with some hints that will help you. But we'll stay tuned for that next week. For now, are there any questions that anyone has from today? I'll try and see if we can unmute everybody.
Muted.
Oh, hang on. I'm pressing the wrong button. All right. No, it doesn't look like I can unmute everybody. Laura, do you know how to do that?
Just having
Unmuted.
now. Mind you, not everyone will have a microphone. Danny, it's saying it's muted by you.
All right. So if anyone has any questions, they can use the little chat box there to put any questions in. Laura, did you have any questions while we've gone through there?
No, I didn't have anything specific, Danny, but I would like to, sign off with thinking if everyone can just go away and have a look at investigate what is your bulk bill rate. Have you looked at that in the past? In those early slides where you're talking about trying to reduce your instance of bulk billing patients, and I like the idea of the butterfly consulting. I think that's really innovative, and I'd like to hear from other practices if they're doing anything similar to try and manage their time wisely.
So with the bulk billing rates, next week that'll be one of the key performance indicators that we look at, and something that's definitely worth practices tracking over time to see how that is going. And I think today we demonstrate that bulk billing rate overall has a significant impact back onto the financial returns that the practice is receiving. And within every practice, you'll probably find that some of your doctors bulk bill at a higher rate than others, and it's interesting sometimes to actually sit down with the doctors that have a high bulk billing rate to have a conversation about what is occurring there. They may not realise that their rate of bulk billing is that much higher than their peers within the same practice. They may not realise the impact that bulk billing decision is having on the revenue that they're generating.
I see that Joshua has raised his hand and has a question.
Yes, thank you, Laura. How are you today?
Very well, thank you, Joshua.
Thank you for this. I missed last week due to the problem. Now,
we'll send you the last week anyway.
Yeah, thank you. Now, how do you find out the percentages of bulk billing? People you have in your practice and people that you do privately? Is there a software you can use for that?
It depends on the medical software that you're using. I know I'm most familiar with ZMed, and it has in it a reporting area where you can do some statistics, and one of the statistics will come out is the fee type, and so you can look at how many of your what percentage of your patients are billed directly through Medicare compared to those that are actually privately billed.
What software do you use, Joshua, for your practice?
I use Best Practice.
All right, that's something we can have a look at in the manual and see if we can come up with the right report for you.
Okay,
Yeah.
thank you so much for that. Thank you for that.
I would expect that best practice has got a report in it that provides you with that
Yes,
information.
I'm sure it would. It's just a matter of
Yeah,
clicking the right button.
they do have the reports, but I'm not sure that percentage is clearly identified.
Okay,
Yeah.
we'll find out.
Okay, thank you.
And if
Thanks for
anyone
that
else has
question,
any
Joshua.
tips for that,
You're
if they'd
welcome.
like to email me, I can share that with the group as well. Any other questions? Danny, actually, you mentioned in your slides that Adelaide's CPI this year was 1.3%. Where would we go to find out what WA's is?
Now, that's a good question, because I had a finance manager who goes in and finds that information. I'm pretty sure it's out of the Bureau of Statistics that provides
Okay.
the CPI index.
Sure.
But I'll check on that, and if it's not, I'll let you know otherwise. But I'm fairly certain that you can get that information from the Bureau of Statistics.
Okay, great, thank you.
It is worth looking at in the context of your own state, because we know that the economy over in Western Australia is vastly different from the economy in South Australia.
It's on its way down.
Yeah, well, not at the same rate ours is, unfortunately.
All right, well, if no one has any more questions or points that they'd like to raise, we can end the session there. And a reminder as well that because this is a three-part webinar, you will need to register again for next week's webinar, and Danny will send out the link for you to do that this afternoon. So just make sure you re-register for next week, and we will send out the slides from last week and from today, and then the final slides next week as well.
Yeah, and you'll have my email address, so if any questions do come up in the meantime, please feel free to send those through to me, and I can get back to you, but also maybe respond to those questions at the next webinar so that everyone can share in the answer from that as well. So please feel free to follow me up afterwards.
Great. Thanks very much for your time once again, Danny.
That's a pleasure. Nice to speak to you all. We'll see you next week.
See you later.
Bye.
Bye.